Hello and welcome to Health Digest, a program where we bring you news, analysis, development, and everything that concerns your well-being. I'm Ogom Sidimbo. In healthcare, safety is not a luxury, it is a necessity. Yet across many health facilities in Nigeria, the silent threat of preventable infections persists. Behind the doors of hospitals and clinics where healing should take place, inadequate infrastructure, poor funding, and systemic neglect are compromising lives. Infection Prevention and Control, or IPC for short, is a shield that protects both patients and healthcare workers. But how effective is that shield when clean water is scarce, protective gear is inconsistent, and essential training is lacking? I'm Ogom Sidimbo, and I welcome you to another episode of Health Digest. On the program today, we'll peel back the layers on the state of IPC in Nigeria. We will explore why implementation varies and what it really means to work in a facility without disinfectants or gloves, and how cultural attitudes, funding gaps, and poor accountability continue to undermine infection control efforts. And what is being done and what must urgently change to protect the health of Nigerians from avoidable infections in our health institutions. And my guest today is Dr. Muzamil Gadaya, Head of IPC Division, NCDC. Thank you so much for being a part of the program.
Thank you very much, Ogom, for having me. Glad to be here.
Okay, so we'll just begin by getting to know what IPC is about and why it's critical in our healthcare settings.
Thank you very much. And you said it rightly in the introduction you did. IPC stands for Infection Prevention and Control. And it is actually to do with policies, procedures, and practices that aim to reduce or prevent, the risk of healthcare or infections in the healthcare space. So be it clinics, hospitals, nursing homes, or anywhere healthcare is offered. Sometimes it can even be the community. So the risk of infection that can be transferred during that process is what IPC aims to address. And it has its roots firmly in public health, medical microbiology, and also some behavioral sciences also, together with human psychology. So it deals with all of this because in really facing the issues of IPC, you need to be pluralistic and also be multimodal in how you think and look at the problem so that you're able to address it effectively.
So looking at the Nigerian situation, how will you assess implementation in our health facilities in Nigeria?
Implementation is at different levels for the different healthcare facilities. So for primary healthcare facilities, for secondary healthcare facilities, for tertiary, you wouldn't expect all of this to be the same. Even the tools used in assessing these healthcare facilities, depending on their level, the IPC tools actually are different. So here in Nigeria, we use the WHO validated tool like the Infection Prevention and Control Assessment Framework, which talks about the full requirements and the minimum requirements. So we have that for different healthcare facilities. So we have for primary, for secondary, for tertiary. But obviously it's a mixed bag. I'm sure you understand what I mean. Different hospitals are at different levels, especially looking back when we started the Turn Nigeria Orange. Turn Nigeria Orange is the name of the National IPC program. It was launched in 2019. And when we started, among the tertiary healthcare facilities, you can say almost all the tertiary healthcare facilities do not have some of the basic requirements for IPC to thrive. For example, having one dedicated, qualified person whose sole work at the facility is just infection control. and then also a budget line for infection prevention and control, and then also policies and guidelines, and more importantly also training, especially professional certification in terms of infection prevention and control. So all of these were lacking when we started. But then when the Turn Nigeria Orange, which is domiciled at the Nigeria Center for Disease Control, began, we were able to work with our partners, like AFENET, USCDC, and WHO, to see that we put the necessary capacities and capabilities in place so that these things begin to get addressed. Yeah.
So you talked about tools earlier. What are these tools of IPC?
So there are those we use annually, which is the one I mentioned. There is an IPCAF, IPCAF, Infection Prevention and Control Assessment Framework. So it's a WHO tool that you can use to really benchmark where IPC is as far as your facility is concerned. And the interesting thing is we also have the IPCAF MR. So the MR talks about the minimum requirements because the full requirements may take some journeying, for the facility to get there. So oftentimes it's important to take it step by step. And as the proper adage goes, that even the best way to eat an elephant is one bite at a time. So for that reason and wisdom, the WHO and other experts in the world introduced the IPCAF-MR, which talks about minimum requirements that should be available for IPC in healthcare facilities. So primary, secondary, tertiary. And so we do that annually.
What are these minimum requirements?
They cut across multiple areas. One, there is program, there is education and training, there is guideline development, there is surveillance for healthcare-associated infections, there is also multimodal strategies, and also there is the workload staffing and bed occupancy, and then also the last but not the least, which talks about the built environment for IPC. So those are the 8. So the questions are sort of framed out of these 8 broad areas. So for a PHC, you see that the indicators are fewer. For a secondary healthcare facility, they're a bit more, and for tertiary, they are also. So for tertiary, there are 45. For secondary, there are 25. And then for a PHC, for a secondary, they have 45, 25, and then 15. Yeah, that's how they spread. So and then for routine practices, everyday practices, the NCDC developed what we call the IPC scorecard. So we use the IPC scorecard in monitoring how changes happen, especially changes that may not often or need to be measured time to time in microscopic level. So practices, policy implementation, guideline implementation, protocol implementation, the scorecard measures that in a way that is different from the IPCAF and the IPCAF-MR. And we also have another one for states. So the important thing is whatever we are doing at the facility also needs to happen at the state, because the states are also the custodians of these healthcare facilities. So they need to also have a program that is domiciled at the Ministry of Health in the state. And we are proud to say we have all the states covered in this regard, 37 state IPC focal persons with programs at the ministries of health in different states.
So we have IPC guideline in Nigeria?
Yes, we do.
So is it been implemented across boards?
Yes.
Fully implemented, it's consistent.
Obviously,
because there's something it can be implemented maybe in some states, like we have with the Child Rights Act that has been domesticated in some states. So is it fully implemented in all states, across board?
So again, just like the
primary, tertiary, and the rest of them.
So the beautiful thing about the IPC guideline, which is the National IPC Manual, is what we call it, talks about the broad areas of IPC. Depending on the level of healthcare system you find yourself, be it primary, secondary, and tertiary, it will really be applicable in your setting. So the implementation level, if you look at it that way, you also find that it's a mixed bag obviously, if you do an assessment now, you may find an implementation level for, let's say, a certain facility at maybe 60%. So what you're expecting is when next you come for another round of assessment, it should be more than, as you know, the earlier or the baseline value where it started. So that is what you expect. So we expect the same thing. So it's a mixed bag, actually. You wouldn't say there is nowhere where this is not domiciled or it's not available. But certainly, the implementation level is not the same across board.
So I need you to talk, because sometimes when we hear about IPC, our mind first of all goes to gloves, you know, we'll go to water. Nobody talks about the other aspect which you have mentioned now. Is that what it is?
Yes, so those are part and parcel of IPC as well.
Okay.
Water, like you mentioned, and you know, Ogom, WASH, which is water sanitation and hygiene, is a fundamental structure or part of the IPC system. The IPC is seen as the software sort of, and the WASH provides the hardware for IPC to thrive. So they go hand in hand, and then there is the new concept introduced by the WHO, which talks about integrated stewardship. So the NCDC, we are doing the same thing with the healthcare facilities, where we talk about antimicrobial stewardship, diagnostic stewardship, WASH, and then last but not the least, infection prevention and control. So all of these are tied together, bundled, and then being implemented together. So they are part and parcel of what you will consider to be part of IPC. The gloves you mentioned is an example of a personal protective equipment. So it's an important wearable piece that healthcare workers must know when to use it and when not to use it. And incidentally, I know you know that the World Hand Hygiene Day for 2025 was celebrated just a few days ago, and that the theme for this year was really about gloves. It says it might be gloves, it is always hand hygiene. So the aim is for it to address that fundamental misunderstanding that if you wear gloves, you may not need to do hand hygiene, whereas you are expected to do it before wearing the gloves and when you take the gloves off, because in itself, the glove is not 100% protective.
So you talked about budget line earlier. What level of financial support does IPC currently receive in Nigeria? Is it underfunded?
Certainly, if you ask what we would want based on our wish list, I would say that we want more, a liver twist kind of thing. But the interesting thing is it's always important to appreciate where we started as a journey. The program, like I mentioned, was launched in 2019. And when we began, we had almost next to nothing. Some funding was provided, I think, in the year 2021, and then 2022 there was nothing, and then 23 there was something, 50 million or so. In 2024 we had nothing given, actually.
So it's a 1 year on, 1 year off
sort of thing. But the interesting thing, like I mentioned, is this year it has been cross-corrected. And this is as a result of the concerted action done by stakeholders around the IPC space in terms of budget advocacy, thanks to AFINET, and then also thanks to colleagues within the IPC space in seeing that happens. And then importantly, thanks to the NCDC leadership. Because in whatever you do, if the leadership sees the vision in what you are trying to do, and they understand how important it is, then it is easy to connect. So in 2025, we were able to get 4 times what we got in 2023. We got 50 million, like I mentioned, in 2023, but in 2025, we got 200 million. So for us, that is a major step in the right direction. And
when you say you got, has it been disbursed?
Oh, that's where I was going to. So the important thing, it's a stepwise thing. They say if you're not on the table, then you're on the menu, isn't it? Right. So at least we made it to the table. And we are working hard to see that beyond the table, we are in the inner room where the release is done. And our hope is that we use, platforms like yours to really reiterate the importance of why IPC is key and why it needs to continue, being funded, and then why the releases need to happen, especially in a timely manner. If it happens, then we have the chance to really do some very solid work with that funding that is provided. Beyond the healthcare-associated infection work, there is also the other side of IPC, which is to do with all the outbreaks that the NCDC is responsible for. So that side of things also is important for that fund.
If I give you the 200 million as government, I say NCDC, this is 200 million for IPC, what will it be used for?
What will it be used for? Very fantastic question. We will use it in multiple ways, and our AOP, which is the Annual Operational Plan, captured that very well. The interesting thing is all of the activities we prioritize doing for 2025 are firmly aligned with what we have in the AOP, and they are also aligned in our National Action Plan for Health Security 2.0, and also the National Action Plan for Antimicrobial Resistance, also 2.0. So all of these activities are contained in there. Certainly where we'll put the 2 million is within strengthening programs, right? Which talks about the policies, procedures, and practices, and then some of the issues around training, of healthcare workers, so that we continue to meet our obligation for joint external evaluation. As you know, also the JE is a way of measuring how well we are performing or otherwise. So all of these things I mentioned are well within the JE framework. So we will also put the 200 million in healthcare-associated infection surveillance to understand the burden, and then be able to see what we can do with stakeholders to also do concerted actions. The last space I would like to put part of the 200 million is in strengthening safety for how safe our healthcare environment is. This firmly talks about WASH, because you can't provide safe care without water, potable water, right? So it's important that is also reflected here. So there are minimum standards that are expected for each of these healthcare facilities. So we would like to see that we put part of the money in programs, part of it in HAI surveillance, and then part of it in, WASH, or safe healthcare environment, as it is firmly contained in our JE, Joint External Evaluation. If we're able to do this, these are actions that are needle movers, and we'll be able to make progress in terms of our scoring, and Nigeria will be able to make that giant leap. So if you look at the quantum of the problem and the size of the 200 million, then you see that maybe we should be asking of the whole, healthcare sector budget, right?
Now, let me come down to worker safety, health worker safety. How does poor IPC affect patient outcomes and also healthcare workers as well?
Interesting question, because one of the fundamental reasons why IPC is important in a healthcare facility is for a number of reasons. One, so that you prevent HAIs, healthcare-associated infections, and then also two, you want to reduce the burden of antimicrobial resistance. And the third one, which is related to what you mentioned, you also want to enhance patient safety and, importantly, healthcare worker safety, including visitors of the healthcare environment, right? So it's important, because one infection that you are able to prevent is one infection that is less likely to occur in a person that operates within the healthcare space. As simple as hand hygiene, it can go a long way in really protecting the patient and the healthcare worker himself or herself. So it's important to continue to reiterate this message that IPC protects everybody within the healthcare space. Certainly, healthcare workers are very much part of the healthcare space, so they are protected, because it ensures they have water, it ensures they have hand hygiene materials, it ensures the environment is clean, and disinfection happens, and then it ensures that peradventure you get exposed, there are services available for you to get some remedial action. So this is part of what IPC does in complement with occupational health.
Okay, so before I let you go, I want you to give us some key strategies you would recommend to improve behavior change around IPC, both from the health workers and also individuals at community levels.
Good. So for healthcare space, the theme of our webinar that we had 2 days ago was incidentally on this. Because the theme of the World Hygiene Day for 2025 is tied to behavior change. And the most cost-effective way in addressing behavior change is using the multimodal approach within that. So it talks about building it. The build it talks about making sure infrastructural provision, supplies that are needed for safe healthcare provision are available, and then also management is fully on board, funding is provided. All of that is contained in the first part, which is about system change. And then the second part talks about teach it, which is training healthcare workers, making sure that they achieve certain level of expertise that they can do the tasks expected of them without having to expose themselves or even cause more harm to the patients that they care for. And then also the third aspect of it is to make sure you check that what they learned or what you thought that they're doing that. So when you check it, you see that sometimes there is a disconnect between knowledge and practice, right? What people know often is not what they do. So if there is that, then you need to understand why that is the problem and then address it. And then also there is the sell it part, because the human mind is quite complex. For whatever you are dealing with, maybe in the healthcare space, as soon as you begin to interact with the patient, there are reminders that need to come to you about how you can protect yourself and how you can protect the patient that you're looking after. So this we do through IEC materials, information, education, and communication materials, which can be printed or digital within the healthcare space, to just say, hey, did you wash your hand today, or did you perform hand hygiene, and all of that. And then at the point of care, just by the bedside, some of these are nicely framed and strategically placed. You see that it reminds healthcare workers about the 5 moments of hand hygiene. And the last part, which is the leave it. Leave it talks about all of this coming together and having the institutional sort of support, leadership support, in making sure that healthcare leaders put their money where their mouth is. If you say IPC is important, antimicrobial stewardship is important, then it's important that you should be seen to act towards that. And the policy that we have in Nigeria, which was approved by the National Council of Health sometime earlier this year, clearly stipulates, national IPC policy clearly stipulates that funding should be available, and this connects directly with funding. So if you have institutional leaders promoting IPC and then making sure it's funded, then you have a way of sending a message that this is important and this is for all of us, including the patients and visitors.
Oh, thank you so much, Dr. Zamil Gadaya, the head of IPC Division NCDC. Don't worry, we know that the government, Federal Ministry of Health, are watching, and we also believe that more funding will come to NCDC to ensure that we improve on our IPC from where we are to maybe a greater level.
Thank you very much.
Thank you so much.
Thank you very much. Thank you for having me.
You're welcome. Thank you so much for your time. Okay, that's our package for today on Health Digest. I'm Ogom Isidibo. Do stay safe.